Good afternoon. My name is Abigail Clark, and I'm a third-year resident in the Internal Medicine Psychiatry program at Emory. This is buprenorphine for the internist. I could spend days talking about buprenorphine, but today we're going to focus on two learning objectives that I hope will leave us with practical clinical knowledge. At the conclusion of this session, we should be able to identify the importance of buprenorphine in treating opioid use disorder and recognize a basic algorithm for initiating buprenorphine in the hospital setting. Opioid overdose deaths are increasing. Since 2013, the number of people dying has risen by almost 4 times, largely because of the increased availability and use of synthetic opioids like fentanyl. But why am I talking about this? We all know that opioid overdose deaths are on the rise. We have seen the impact in our communities, our patients, perhaps our personal lives, and of course on the news. We know that the opioid epidemic is touching everyone in our communities. Yet those who use opioids can still find it challenging to engage in healthcare because there's such a long history of negative stigma toward those with opioid addiction. Addiction medicine and psychiatry providers have worked to reduce this stigma by reframing opioid addiction as opioid use disorder, naming it as a chronic disease that, like diabetes or HIV, can change over time, has ups and downs, but ultimately needs chronic treatment. One of the best medications we have to treat opioid use disorder is buprenorphine. Now, before we get into the specifics of buprenorphine, let's put its effectiveness into perspective by comparing it to medications we know save lives every day. What would you guess is the number needed to treat with a statin for primary prevention of an adverse cardiovascular event? 83. What about aspirin for secondary prevention of stroke? 140. What do you think is the number needed to treat with buprenorphine to maintain abstinence? 2.5. And to prevent overdose deaths, that number is 11. Overall, buprenorphine has a lower number needed to treat than nearly any medication we have embraced without hesitation. You may recall from your medical training that buprenorphine is a mu-opioid receptor partial agonist. The drug binds to the opioid receptor, generating only a limited effect, which in turn is what makes buprenorphine a very safe and effective drug. It can be initiated within a few hours of opioid withdrawal to relieve symptoms. It also has a low risk of physical dependence and a low risk of overdose because it is a partial rather than a full agonist of the mu receptor. Plus, when buprenorphine is combined with naloxone, which is the antidote for an opioid overdose, it becomes even safer. And since December 2022, there is no special waiver required to prescribe buprenorphine. Any provider with a current DEA license that includes Schedule III authority, meaning the ability to prescribe controlled substances, can prescribe buprenorphine. This is an incredibly safe drug. Now let's learn how to start buprenorphine by reviewing a basic algorithm for initiating it in the hospital setting, keeping in mind that there are many different dosing strategies for initiating buprenorphine, all of which can be effective. We will be discussing a high-dose macro-induction strategy, which is that most often employed in the hospital setting. Before starting buprenorphine, we must be familiar with the clinical opioid withdrawal scale, also known as the COWS. This is a validated, clinician-administered 11-item scale used to rate common signs and symptoms of opioid withdrawal, like yawning, sweating, and heart rate. Each symptom is given a score from 0 to 4 or 5, depending on the intensity of the symptom. Then the total score is used to stratify the severity of withdrawal. This is important because we use the withdrawal severity to determine the dose of buprenorphine administered in acute withdrawal. This is a wonderful paper by Herring et al. From 2021 that was published in JAMA. It provides a simple, widely used algorithm for initiating buprenorphine in the hospital setting. I will have this algorithm available at the end of the presentation and a QR code for you to reference in the future, but I always find algorithms easier to learn when I apply them to a patient, so let's do that. Our patient is a 35-year-old woman with severe opioid use disorder. She's been using heroin for the last 15 years, survived 2 accidental overdoses, and is now admitted to the hospital for a bloodstream infection after using unsterile needles to get heroin into her body. She's been in the hospital receiving IV antibiotics for the last day and a half, and now she says she wants to leave. She feels nauseated, everything hurts. She knows she needs heroin to stop her symptoms. We want her to stay. So we offer buprenorphine, describing how it can help withdrawal symptoms and reduce her cravings for heroin now and in the future. She's reluctant, but ultimately agrees to stay the night and work with us as we start buprenorphine. The first thing we need to do is assess her withdrawal severity. We measure her COWS score, and it's 15. This is higher than 8, which is the threshold to give a dose of buprenorphine. But how do we know how much to give? We classify her withdrawal severity, aiming to give 4 milligrams for mild withdrawal and 8 milligrams for moderate to severe withdrawal. Her withdrawal is classified as moderate, so we administer 8 milligrams of buprenorphine. And on the slide, I have pictured the actual buccal film of buprenorphine we will give the patient. Then we wait 30 to 60 minutes and reassess her symptoms. Her COWS is now 9. It's still higher than 8, and her withdrawal is classified as mild. So we administer 4 milligrams of buprenorphine. We check in again after another 6 hours or sooner if she reports withdrawal symptoms. Her COWS is 4, which is less than our threshold of 8, so we do not administer buprenorphine. We continue to check in on her through the day, and she does not need additional doses. We calculate her total dose for the day as 12 milligrams, keeping in mind that the usual maximum dose of buprenorphine on day 1 is anywhere from 12 to 16 milligrams. The next morning, we give her a 12 milligram dose because the starting dose on day 2 is always the total dose that was required on day 1. Then we continue to assess her intermittently through the day and administer more buprenorphine as needed based on her withdrawal symptoms. After about the first 2 days, we find a maintenance dose that alleviates her withdrawal, which is 8 milligrams of buprenorphine twice a day, and this is a very typical starting maintenance dose for buprenorphine. She is discharged, and like almost all patients on buprenorphine, she'll take the medication indefinitely, because opioid use disorder is a chronic illness that requires chronic treatment. In an ideal world, she would follow up with an addiction specialist for continued treatment. But most of us function in communities where that's not a readily available option. So we, as general internists, as primary care providers, should work to be prepared to prescribe buprenorphine for our patients with opioid use disorder. And if our patients are struggling, be aware of resources in our community where they can receive additional care. I hope I have convinced you of the benefits of buprenorphine, but in case I have not, buprenorphine reduces mortality by 50% in patients with opioid use disorder. This is a life-changing medication that can make a huge difference for our patients. If you're interested in keeping some information from this talk, I have a QR code here that links to the algorithm I discussed earlier, as well as some key points about buprenorphine. Thank you.